In this episode of the ASC Podcast with John Goehle, we cover the latest updates from the ASC industry, review requirements for your annual governing body meetings, and in our focus segment, interview Jamie Miller with SCA HEALTH about cultivating a safety-first culture, leadership's role in patient safety and employee retention. Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We'd like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solution, your all-in-one healthcare regulatory compliance software, Trivalence, offering a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which is the only digital narcotics cabinet specifically designed and priced for surgery centers, helping to standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. Welcome to episode 236 of the ASC Podcast with John Goehle, recorded on December 13th, 2024, from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry, and he is a highly regarded speaker on topics related to regulation, accreditation, and finance management.
So I don't know how wise it is to be recording on Friday the 13th. We've already had some problems with our equipment here as we're recording. So we'll see. Hopefully everything will work out well. I'm recording this, and then quickly we'll be heading out to a Christmas party for one of our clients in New York City. So probably won't actually publish it until sometime tomorrow. But we want to wish everybody a very happy holiday season. We're not sure we'll have another episode before the end of the year. We'll certainly try, but it's been a very busy time. Sue and I just came back from a wonderful cruise. It seemed way too quick, though. We enjoyed ourselves immensely, and then during the cruise, we found out that Rosie it was ready to have another litter of puppies. So this will be Rosie's 3rd litter. I guess it's important for us to note, for those of you who might not follow us all the time, that Rosie is our company mascot. She's an English cream golden retriever, and she has already had, as I said, 2 litters of puppies, and very excited about this. Yeah. She's not terribly happy about it, I think. She just doesn't like the car rides to go to Cornell University, where we have all the magic occur. We have been very busy in the company with some new centers, some realignment of what's going on in ambulatory healthcare strategies. So more to come on that in the near future, but we're very excited about our new centers up and running. As we get to the end of the year, we know that many of you that are CASC or CAPE certified, that is the Certified Ambulatory Surgery Center Administrator and the Certified Ambulatory Infection Preventionist credentials, you might be short on your AEUs or your IPCHs. So if you are and you need a few extra credits or a lot of extra credits, make sure you visit our ASC-Central website. So that's ASC-Central.com. I'll provide a link in the show notes here so that you can get to it quickly. It always seems to that we have a big rush at the end of the year. I know you're the one that issues the AEU credit certificates, and I know you'll be very busy over the next couple of weeks as people realize that they're a little bit short on their credits.
So Johns Hopkins scientists recently developed a color-changing hydrogel that can help to reduce complications of cataract surgery. And cataract surgery, of course, is one of the most common procedures performed across the world. Now, when removing the cloudy lens to replace it with an artificial lens, a clear hydrogel is injected into the eye to keep the eye inflated and protect the cornea. And if that is not completely removed afterwards, patients can experience complications such as pain, pressure, and vision loss. Also, it can be a little tedious, I think, for the doctors to figure out, to make sure they've removed everything because it's a little hard to see. So this new gel is clear under normal lighting conditions, but it turns a fluorescent green under blue light. So that'll enable surgeons to better visualize as they're trying to completely remove that gel. And they noted that the newest digital microscopes can also highlight the gel without adding an additional blue light. So the idea has been tried before with just putting a dye into the gel, but sometimes the dye would leak out of the gel and spread into the eye. So with this new product, the dye is chemically bonded to the polymer gel. Now, currently, this is only in animal trials, but it should soon move into human testing. And the gel and the dye have both been found to be safe for humans. And the gel also is very similar to what is currently being used. It still feels, the same viscosity and still should feel familiar to the providers. So they just have to check to make sure that together it's safe and effective. So hopefully that can be out soon. I mean, it seems like a pretty simple idea, and I know there doesn't tend to be a whole lot of these complications, but I would think it just might make it a little more efficient when the doctor can really target what they're trying to pull out. So,
and again, anything that we can do to improve safety in our patients is of course, as long as it doesn't cost a lot of money in the process.
Yeah.
That you didn't mention anything about money here.
Because it isn't a total thing yet. But I wonder, it seems like, and I know the other day, a podcast or two ago, we talked about the adding color to some of the wipes, to the sterilization or the cleansing wipes. It seems like there may be other uses for this technology too. Just anytime you have to really identify what you're working with, I think really helps.
And Sue, GLP-1s are still in everybody's something we're always talking about. So I guess you have some new information.
I do, and I'll mention this later. But of course, I'm just going to start off by saying this is not advice. This is, that this is really for your providers to decide. But an OR Manager article by Matt Danford on November 7th noted that there was joint guidance from some U.S. medical associations, including the American Society of Anesthesiologists, the American GI Association, and the American Society for Metabolic and Bariatric Surgery, that advises that most patients on GLP-1 medications can continue them even before surgery. The new recommendations emphasize individual risk assessments to balance the risk of stopping the medication, such as if it's a diabetic patient, you can run into blood sugar issues, and also the risks of delaying surgery if it's a last-minute surgery. Do you want to delay it while you're waiting? Giving them those few days or the week. But then weighing that with the risk of aspiration, of course. They suggest considering a 24-hour liquid diet or adjusting the anesthesia plan. And high-risk patients might also warrant a pre-surgical ultrasound assessment of the stomach contents just to double-check that. The most at-risk patients are those who have recently started the medications or recently increased their dose, and the ones who are experiencing side effects such as nausea or constipation, because that's just sort of a sign that the food's not moving through well. And again, I'm not presenting this as advice. That's up to your providers. But I just wanted to point out there are so many different views and information coming out on this that patients could really get confused or get conflicting advice maybe from their PCP or, they've heard their friend didn't have to stop it or whatever. So I think it's just more important than ever to have a really solid policy on this and give a really thorough pre-op instruction to your patients and double check when they come in that they haven't heard something different. I just think there's a lot of information out there flying around, and we haven't come to an exact, definite decision yet, I guess.
Yeah, I see two things in this. First of all, it's important to realize that there's a big difference between a patient that is on the GLP-1 because they have a very acute situation or acute disease, and therefore the risk, as you mentioned, there could be much more of a risk of stopping this procedure as opposed to people that are on purely for weight loss, where one could argue that that it might not be worth the risk to not stop it. I think, but the second thing is the most important thing. These are not decisions that most of our listeners are going to be making, or certainly us.
just be sure that you're really solid on your policies and that you've had some real good meetings about this, or your providers, not you.
Right. That, my point exactly is that we want to make sure that you have documented conversations in your quality improvement, your medical executive committee, if you have one, and your governing body, so that it's very clear in your policies. We as surveyors, when we come out there, we are going to be asking about these types of policies as we talk about, who are appropriate candidates for the procedure and what instructions you give to the patients beforehand, and what are the ramifications of not following the instructions you might have. Are you indeed canceling those cases? Is the doctor evaluating the patient beforehand? Sue, in the last episode, I talked about how there had not been any recent quality, safety, and oversight memos, or QSO memos. And, of course, I should have knocked on wood because, indeed, one came out just after that podcast. So November 21st, 2024, QSO-25-09-all was issued. And I'll provide a link to that item. It's not something that's going to affect, hopefully, most of you, but I do think that it's important that everybody understand how immediate jeopardy works. So the subject of this QSO was referred to as Revisions to Appendix Q Guidance on Immediate Jeopardy. And as I said, I'll provide a link to this. Let's start by talking about what immediate jeopardy is. I'm hoping that most of you that are listening have are not up to speed on what's going on or what immediate jeopardy is. But of course, in your lifetime, it's certainly possible that you would have or you might in the future. So immediate jeopardy, according to CMS in Appendix Q, says immediate jeopardy, or an IJ, represents a situation in which noncompliance by providers, suppliers, or laboratories, hereinafter referred to as entities, has placed the health and safety of recipients in its care at risk for serious injury, serious harm, serious impairment, or death. And these situations must be accurately identified by surveyors, thoroughly investigated, and resolved by the entity as quickly as possible. In addition, noncompliance cited in an IJ is the most serious deficiency type and carries the most serious sanctions for entities, meaning, and this is my own note here, meaning that you really can't continue operations until you fix that problem. And continuing with Appendix Q, it says, an IJ situation is one that is clearly identifiable due to the severity of its harm or likelihood for serious harm and the immediate need for it to be corrected to avoid further or future serious harm. So the intent of this QSO is as follows. The core Appendix Q contains a number of key changes from the previous version of Appendix Q, and those changes include revised reference to subpart 11 in the appendix. And this is what it talks about, the likelihood instead of potential. In other words, the previous version of Appendix Q suggested that a potential for serious harm might constitute immediate jeopardy. And it makes it clear that in order to cite an immediate jeopardy in situations where recipients have not already suffered serious harm or injury, impairment, or death, the nature and the extent of the identified noncompliance creates a likelihood or reasonable expectation that such harm will occur if not corrected, not simply the potential for that level of harm to occur. So instead of using the language, there's a potential for harm, you need the surveyor is going to have to identify that it is likely, that it's quite likely that harm will occur. And that is quite a sea change, really, in that definition. So I think that's going to set the bar a lot higher for immediate jeopardy situations. And I think this really provides surveyors with a lot more information about this. And then secondly, it talks about culpability has been removed. So the previous version of Appendix Q made culpability a required component to cite an immediate jeopardy. Because the regulatory definitions of immediate jeopardy do not require finding a culpability, that requirement now has been removed and has been replaced with the key component of noncompliance, since the definitions of immediate jeopardy require noncompliance to be the cause of the serious injury, harm, impairment, or death, or the likelihood thereof. So again, no culpability. So again, I'm going to provide a link to that. Sue, at some point we probably should have a much more extended conversation about immediate jeopardy. Again, not because it's likely, but it's good for people to know. I mean, I use immediate jeopardy frequently when I'm talking to centers that when we're doing mock surveys to emphasize the importance of correcting these problems. Usually it's something that I suggest to the administrator or director of nursing to get their governing body, get their doctors to understand that if you don't fix this problem, you're actually going to have to shut down. And that usually gets them to come on board with those changes that are necessary.
Yeah, and even just all the different, the condition level.
Right. That's a good point.
To understand all the different levels of citations.
Yeah, so put that down in our notes for a future episode. We're coming to the end of the year. Hard to believe that 2024 is almost over, which means that you will be having or are about to have in the new year an annual governing body meeting. Most organizations tend to do it at the end of the year or the beginning of the next year. So I thought it would be a good time to kind of go through some of those things that are required at the end of the year. Now, this list is extensive, so be prepared. You might want to listen to this section a couple times. So one thing that is required by the accreditation organizations is annual evaluation of your goals and objectives. We refer to this as strategic planning generally. But what you want to do is you want to talk about your organizational goals, your objectives for the next year. Usually what I like to do is I like to include the infection control goals and objectives, which come right out of your infection control risk assessment, your quality improvement or safety goals and objectives coming out of your quality improvement committee, and then your emergency preparedness goals and objectives, which are required. This is actually required by CMS, by the way, also from your hazard vulnerability analysis. So again, all of those things flow into your goals and objectives. So I, as a surveyor, when I go out, I'm going to want to look to your governing body minutes to see that there's been a conversation about the goals and objectives there. Second is that you want to make sure you do an annual financial review and document in your minutes. This isn't so much for the accreditation organizations, but this is a corporate requirement as part of your limited liability company or your subchapter S company requirements with your Department of State. And now, this isn't always done at this annual meeting. Often you wait for the tax return to be completed for doing this, but make sure that at least on an annual basis you do a financial review of the prior year's financials and tax returns. On an annual basis, you're required by CMS to review all of your contracts with the governing body and determine that all of those contracts are in compliance with federal, state, and local laws. And again, you want to document that in your minutes, as well as making sure that the administrator or director of nursing, whoever does these contract reviews, has documented that somewhere else in their documentation. Also, on an annual basis, you want the governing body to review any updates to federal or state regulations as well as accreditation standards. And again, document that the governing body has reviewed those changes or any changes that might have occurred and have given direction to the staff to implement any changes that are necessary from a policy standpoint. We always talk about policies and procedures. Those, of course, have to be approved on an annual basis. So one thing I should point out here as we're halfway through this list is that you don't need to do all of these at once. I have many organizations that actually spread these annual requirements throughout the year. Just makes those meetings a little bit more meaty, actually, and doesn't make them as long because this annual meeting can be quite long. So policies and procedures, to be honest with you, they're not always done or approved at the annual governing body meeting. It's sometimes something that you do at another meeting.
And you can make a note, maybe have all of this, because that's the only thing it can get hard to keep track of it all. So just, next due on whatever the date will be.
Very good point, Sue, is that we like in our minutes to actually list all of these things that I'm going through right now in every set of minutes and then just say last reviewed, on such and such a date, next due on such and such a date. If you have a tissue bank, make sure that you would do an update to your tissue bank policies and procedures annually. Risk management, adverse and incident reporting, you're going to want to summarize all that information on an annual basis, usually as part of your quality improvement report. Do an annual review of your safety program, of course, an annual review of your emergency preparedness program. Again, often these things can be rolled into your policies and procedures. I do like to pull them out separately so that we can, because those actually show up separately in most of the accreditation standards there. So just make sure that you have an annual review documented and that the new program for the next year or the revised program, or even if there is no changes, that you agree to that the program continues as is. An annual review of your infection control plan is absolutely critical. That's something that the governing body has to look at. And you're going to want to refer to that annual review. You're going to want to refer back to the infection control risk assessment that's performed by your infection control coordinator. Annual review of the quality assurance program, again, something that you want to document directly in the minutes. And when we're talking about this, we want to make sure that the effectiveness of that program is also reviewed. I usually include language like the governing body has reviewed the quality improvement program activities for the past year and has found the activities to be effective in maintaining a high quality of care in the organization. Or don't be afraid to say, that we have identified a couple things that we would like to improve in that program, have made changes. As a matter of fact, I, as a surveyor, like to see that you've actually done that rather than just using standard language that, this year we've decided to implement a couple new infection control standards or quality improvement measures. Again, all of that shows that you have a robust program. With regard to facilities and equipment, make sure on an annual basis the governing body reviews and approves the NFPA 99 risk assessment, which I think we've talked about a couple times in some previous episodes. If not, you might, if so, you might want to go back to some of our risk assessment episodes. One of the accreditation standards is that you do an annual review of your patient rights and responsibilities. And then a big item is an annual appointment of officers. Now, this gets a little bit tricky because not all of the accreditation organizations require you to do an annual appointment of officers. But the problem comes in that we as a surveyor, when we come out, we want to see that those people have been appointed. And if they've been in that organization for 20 years, that initial appointment could be 20 years ago. So I highly recommend that you just do an annual appointment of all the officers. I want to run down that list of the various officers that are required. Now, keep in mind, there are many situations, right, Sue, where like one person is listed for, the vast majority of these items. So this is just a good list. I'm just going to run through it quickly. Annual appointment of the administrator, the clinical manager, the medical director. If this, by the way, with regard to the medical director, if an anesthesiologist is your medical director, you will also need to have a specific director of surgical or medical services. And as I said, a director of surgical services also if the medical director is an anesthesiologist. An anesthesia director, business office manager, a quality assessment and performance improvement coordinator, an infection control coordinator, which has to be a licensed clinician, by the way, an education coordinator, that's kind of optional, a laboratory director if you have a laboratory, which most of you do, a pharmacy director, a radiology director if that's applicable, a safety officer, a risk manager, a compliance officer, a privacy and security officer, a medical records director, or it can also be titled health information systems director, a tissue bank compliance officer if that's applicable, and a laser safety officer if that's applicable. So I think that's a pretty comprehensive list, but depending upon the services that you offer, you might have some other positions also. Now, I want to add a couple things. I think we've mentioned this a couple times in previous podcasts, but one thing that we're adding to all of our annual meetings is an annual review of the operating agreement. One thing that I found is that often, unfortunately, ASCs are not really reviewing or following the requirements of the operating agreement, like who's appointed, how frequently they're appointed to the governing body, et cetera. So make sure that you do review that operating agreement. You're not approving it. All you're doing is showing that you've reviewed it, and if necessary, any changes are going to be referred to your attorney to make those changes. In the same manner, medical staff bylaws. Actually, much more frequently, I find organizations are not following their medical staff bylaws. And so to avoid that situation, I like to do an annual review of the medical staff bylaws. Again, you're going to want to have a lawyer involved if you do have to make these changes, and read through the medical staff bylaws, because usually this is going to require a special meeting of your medical staff in order to approve them. You might also want to look at your medical staff bylaws to see how members of the Quality Assessment and Performance Improvement Committee are appointed. And then if they are appointed on an annual basis, make sure that that's listed in the governing body minutes. You also need to do an annual review of the scope of services, or we often call it an approved procedure list there. And again, that has to be done by the governing body. Also, make sure that on a periodic basis, and again, good idea to do it on an annual basis, approve the formulary that you have, your high alert medication list, the confused drug name list, or look-alike, sound-alike medication list. And then a new requirement under USP 800 is that you have to do an annual risk assessment of hazardous drugs. This is something that usually, assuming you have a pharmacy consultant, that individual can do that for you. And I also want to remind everyone that when you document in the minutes approval of doctors to work at your center, that you use the language that the governing body has approved the privileges of those doctors. I've been seeing quite frequently, unfortunately, that the governing body minutes will say something to the effect they approve the credentials of the physicians that are appointed. And that's not proper language. Credentialing is the process of reviewing that individual's information to determine that they're appropriate to grant privileges to. But the governing body is actually granting privileges. And you're going to want to document in the minutes the specific dates that those privileges are going to be approved for. And also make sure that if you're doing reappointments, you're doing recredentialing and reprivileging reappointments to the medical staff, that you document in the governing body minutes that the governing body has reviewed the peer review for those individuals to as evidence that they deserve to have their privileges extended.
And we do have podcasts on the whole credentialing process as well as educational conferences if some of this sounds confusing to you.
Right. Yeah. We have a good day and a half conference we did in January of 2024, and that's available on ASC-Central.com. It's a good conference not only for leaders, but also for the people that might actually be doing that work. If you're lucky enough to have somebody that does all that work for you. Sue, during the Washington State Association meeting last month, I had an opportunity to interview Jamie Miller. She's with SCA HEALTH. She did a wonderful presentation, which I very much enjoyed, on cultivating a safety-first culture, leadership's role in patient safety and employee retention. So I thought I would include that interview in our focus segment here. So let's take a short break, and when we come back, I interview Jamie Miller with SCA HEALTH. It's been a long day, and the surveyor's just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. I'm here at the Washington State Association meeting. It is November of 2024. I'm here with Jamie Miller. She is with SCA HEALTH. And Jamie, we're recording this on the second day of the conference. You did a session called Cultivating a Safety-First Culture, a Leadership's Role in Patient Safety and Employee Retention. And we, on the podcast, of course, talk about that topic, or talk about leadership quite a bit, and it's one of our passions with our leadership boot camps, et cetera. So I thought you would be a great guest here. I think we're doing this for the special episode for Washington, but I think you're also going to be on, one of our episodes that we go nationally. So can we, first of all, introduce yourself and what you do with SCA?
Yeah, so my name is Jamie Miller. I'm a registered nurse. I just recently also got my master's in healthcare administration. But I've been in the ASC industry for over 23 years.
Gotcha.
I was one of those people that got hired as a new grad years ago when we didn't do that. And was able to grow up in the industry.
Yeah.
So ended up at SCA HEALTH because my specialty is in clinical quality. I'm certified professional in healthcare quality.
Okay.
And they were looking to, grow their quality program years ago, hired a lot of us, and I was one of their external hires.
Right.
So with SCA Health, I help support centers with their clinical issues in Washington, Oregon, and Utah.
Gotcha. So actually, let's start with, before we actually get into your presentation, I'm fascinated by the fact that you got into the industry without going the traditional route.
Yeah.
Correct?
Correct.
So what drove you to do that? Because I think that's an important lesson for us to learn here, because we know that's starting to happen. So how do we prepare, people for this industry if they haven't gone the traditional, or what used to be the traditional route, through the hospitals?
Yeah, well, luckily, I was in my last year of my program and got to do my preceptorship at a small hospital who had an outpatient surgery department.
Yeah.
And I got to spend a couple of weeks there and realized what a joy it was to see a complete care front to back in one day.
Yeah.
Right? I'd been working at the hospital before that as an LPN. And, you often didn't know what happened to the patients, or, overnight things would happen and things would completely change. And I really enjoyed being able to see a patient through front to back and know that they were having a good outcome. I also enjoyed being able to work with patients in a way that was, they wanted to be there.
Yeah.
Right? They were choosing to go to surgery to improve something in their lives, and really, really enjoyed that aspect of working with patients who wanted to be in that part of the healthcare system. I also had a new baby at the time, and really enjoyed the thought of no weekends, no holidays. Yeah. So I think if we can get that out to more people who are in nursing school, what a great industry this is. And then we take the time to invest in them. Like my center invested in me. They gave me almost a 6-month orientation, which I know is unheard of, but they felt like clinical quality was really important. And until I had the skills necessary, I was definitely not going to be allowed to be on my own. And so if we can get them interested in the ASC industry and support them during that really critical onboarding period to where they become extraordinarily competent and valuable members of our teams, I think we'll be good to go.
Well, and you bring up something that is one of my passions, certainly getting people in their training involved, or shortly after that training is done, involved in surgery centers, because for so long it's always been about the hospitals. You get out of the nursing school and you learn that that's where it is, and that's where you've got to go through that training, and that is changing post-pandemic, even more so, I think, because of the demand and because of the stresses that the nurses go through in the hospital.
Absolutely. And this younger generation are looking for that work-life balance. Right?
Yeah.
So, I am of that generation that really is just work. But I realized when I came into this industry that this is a little bit different, and it's kind of nice. And so many of our younger nurses, that is one of their priorities. Work-life balance. Right. So they don't want to work, those 12-hour shifts with all those overtime shifts like they used to. So it really is a great draw to the ASC industry.
So talk about your presentation and what was your focus there. Well, first start, what drove you to do this session?
Yeah, so I have a passion for patient safety. I have from the very beginning. It is why I do what I do. I really feel like it's the most important thing that we do. We are, a clinical industry, and want to make sure that our patients are a priority, right? And as leaders come up through, they have so many competing priorities, right? And so I wanted to just draw the focus back to how do we create a culture that is about patient safety while still having a successful business, right? Because we know that's important. But how do we ensure that we have that patient safety model in our centers? And what is our role as leaders to cultivating culture, right? Because if you get the culture at your center right, everything else happens, right? Growth happens. Doctors want to come work in your center. Staff want to come work in your center. Your employees become your best advocates in recruitment. You don't have to pay all that money for recruitment. And then people stay because it's a wonderful place to work. So that's what drew me to wanting to present on this. I have a passion about it. And I spent some time during the presentation talking about employee engagement. And I think that's where, we really need to focus. Sometimes ASCs don't focus on employee engagement, right? They don't do employee engagement surveys. They don't know how engaged their employees are. And they don't spend a lot of time thinking about it. But studies show that only, 13 to 15% of employees are actually engaged in the workplace. And in healthcare, that makes it dangerous.
Right.
Right? When only a small percentage of your employees are there really driving improvement in it day to day and not just showing up for a paycheck, or some of our employees are actually actively disengaged, meaning they could be working against you and against patient safety. And that's a thought that's dangerous and we don't want to think about, but it's important to think about it. So,
and we've all seen it.
Yes.
We've all seen it in our organizations. Yeah.
Yeah. And we see it in the national news, right? Nurse, chooses to do something that they know is maybe not best practice, and there's detrimental outcomes to that, right? So we need those engaged employees, and one of the easiest way to do that is to have a healthy culture.
Right.
And so when you want to drive that patient safety culture, I talked through, accountability, how important it is, right? We set these expectations, we design these great policies and processes, but if we're not out there actively holding people accountable to those processes, they really easily turn into normalized deviance, right?
Yeah,
which can be the bane of our existence in healthcare, and especially in ASCs, when we know we're supposed to be doing this, but it's more efficient to do it this way. That's just a redundancy, right? But we forget that redundancies are put into healthcare on purpose because humans make mistakes, right? And when humans make mistakes in healthcare, the effects can be detrimental to our patients.
Right. You're touching on something I think that is important, and one of our ongoing themes is that while profitability is important, that shouldn't be your primary focus. We've seen over and over again in our industry that building a good culture, building a good organization, a safe organization with high quality output can drive profitability.
Absolutely.
Instead of the other way around.
Yeah.
Did you talk about that? I know that's something SCA thinks.
No, I absolutely did, because I'm not naive, even though I work just in clinical and not in operations. I've been around ASC operations for years, right? You don't work in a small physician-owned ASC for 16 years and not get involved in operations, right? Even though it wasn't my primary roles. And so I know that we have to have profitable businesses, right? To be able to provide that environment, that safe environment for our patients, and that safe environment for our nurses, and an environment where they feel comfortable speaking up. It's important. And we did talk about that in part of employee engagement, right? So I can't remember the exact statistic that I presented yesterday. I think it's like businesses are 58% more profitable and grow better if they have engaged employees, right? So, but sometimes we drive the growth first, but really it's that culture and that safety and that employee engagement that can drive profitability for you. And I spoke about how important it is that we allocate our attention and resources to things equally, right? It's really easy to talk about profit margins and efficiencies and turnovers and staffing. And we need to talk about those things because they're very important to our businesses. But if we appear to be spending too much of our focus or too much of our time on those things, our employees, rightfully so, get the impression that those are the most important things. And so they will maybe cut corners when they shouldn't, right? Because they're trying to make the organization happy.
And they're often incentivized for doing that as opposed to incentivized for high quality.
Right. And so when you start from the other lens and make sure that all of your employees or teammates know that patient safety is our focus here, and we know but by providing this incredible high quality care, that the rest will follow, right? I told you I worked in this, I didn't say, but I worked in the same surgery center for 16 years, physician owned. And from the very day that I joined that organization, it was made clear to me that patient safety was the priority. And sometimes that's not the case, right? And so, but I always felt comfortable speaking up. I always felt supported in my career, and we never had to look for employees. Now, I know the market has changed, right? But every time a role would open up, one of our employees would be like, oh, I know so-and-so. And it would be wonderful if we could get her over here because she thinks like we do, right? And so when you continue to get those, employees internally and you drive that culture from the beginning, the rest follows, right? The doctors loved working there, right? They would recruit other doctors to come work with us. We never had to really focus on those things as much as some people do because it really came from, this is a great place to work. It's a great place to operate. And we never had to chase those doctors or chase those cases or really even chase the dollars. And so I was lucky to grow up in a center like that. But I want all of our centers to be like that. right? Because it really is where our patients are safest and our employees are happy, our doctors are happy, and that makes it a great place to go to work.
So that drives the question, how do you develop that environment?
Yeah.
What are the simple things? And you did a number of exercises, which I did not participate in because I was my session was right after yours. So
you're kind of getting ready.
I was, but I thought it interesting because it did force the audience to start thinking about how they were going to change based upon what you were talking about, or perhaps to look internally to what they're doing that might not be necessarily healthy for that organization or helpful to that organization. So what do you do to drive that type of environment?
So you have to make a plan.
Yeah.
Right? You have to make it a priority and not just something that you're like, oh yeah, we're going to improve our culture.
Yeah.
How are you going to do that? Right? And what are you going to do to make your team know that you're serious about it and that you mean it and that you care about them? Because that's what they want to feel, right? They want to feel cared about and invested in. So we talked about certain things that you can start, stop, and continue, which I think was one of the biggest exercises, maybe one that you saw. But, in your center to drive this great culture and drive patient safety and employee retention. And it was really simple things, right? Like daily safety huddles, an evidence-based practice that our hospitals have been doing for years and years and years. A lot of our centers don't do those. Taking that 5 minutes, 10 minutes in the morning, stand up, what could go wrong today? Right? Based on what we know about our patient population, our supplies, any, recalls or new equipment, what could go wrong today and what are we going to do to prevent it? Like having those really important conversations every day. Right?
And in a huddle format where it's very contained, you're able to get everybody in the hallway. They have no excuse for not being able to be there, and that conversation occurs very quickly.
Yes.
If people are not familiar with the huddle concept, I think by now everybody does. But that's fascinating because I've always thought about the huddles as being, okay, this is what's going on today, but to focus it from a safety standpoint is a fascinating idea.
Yeah.
It drives that message.
And evidence shows that it works.
Right. Interesting.
Right? When you take that 5 or 10 minutes. And a lot of our ASCs, right, we're an efficient operation. They just say, we just don't have the time. Right? Hospitals have the time. They have more people, whatever. But when a safety event happens, think about how much time that takes and really what the consequences can be for our patients. And so we have to make the time. Right. So that was one of the things that I suggested that, you start or continue, and then, our medical directors, right? Sometimes not utilized resources, but they can be our biggest partners in patient safety. So I suggested that, if you aren't doing medical director one-on-ones on a regular basis, that you start doing those. Some things that we talked about stopping, kind of a culture of negativity, allowing that maybe gossip or negativity to creep in because, we do have that kind of groupthink mentality. And so if you allow that to start happening in your center, it can just really spiral out of control. So making that an expectation that's not what we do at our center. We're not going to gossip. We are not going to show up and think about and be negative all the time. Really, those are some things you should stop.
And that's got to be driven from the top, from the leadership.
It does. And I talked about how sometimes we allow those things, right, without knowing it, right? You hear some people gossiping in the break room, but you've got somewhere to be or really something more pressing, and you just walk on by, right? And so that sets the tone, right? That's okay here, right? I'm tolerating that. I'm not telling you it's okay, but by me knowing it's happening and not doing anything about it, that sends a big message to your team.
So for our audience, and I think you kind of did this during the presentation, can you just drive home like what maybe 3 things you could do after you listen to this podcast, to improve your situation in your organization from a standpoint of driving a cultural change so people want to stay with your organization and drive better quality?
Yeah, absolutely. I think number 1 is make a strategic plan around culture. Right? We make a strategic plan around growth. We make a strategic plan around, retention or, getting new physicians in the building. But do we have a strategic plan to improve cultures? What are your action items you're going to work on, next week, next month, next year about improving your culture? And then do those things, prioritize them, put that on your calendar. I'm going to think about the culture, where we're at, what we need to do next, every quarter, every week, every month, whatever you can start with is okay. So I think that would be the first thing.
Well, and let's just stop there for a second, because we know that we have to develop a strategic plan or a set of goals and objectives. Mm-hmm. We often focus on issues around quality, which is important, obviously. Yeah. Things around, maintaining your license, your certification, your accreditation. What you're saying here is, of course, drive right down to one of the most important things, the importance of having your employees want to stay with your organization and become engaged in that organization. So put it right into your strategic plan right from the very beginning.
Absolutely.
And it is a requirement that you have a strategic plan as part of your accreditation. So here's a simple solution for our audience as to what to put into those plans as they're getting prepared for a survey.
Yeah, absolutely. And then I think number 2 is you need to be very cognizant as a leader that you're on display and people watch what you do and they take their lead from you. Yeah. So you need to think about, how are you allocating your attention and resources? What do you pay attention to on the daily, right, or monthly? When you're having your meetings, making sure that patient safety is up first. Right. We talk about patient safety before we talk about anything else. Telling those patient safety stories, to your physicians, right, at those board meetings. Take that time with them. It doesn't have to be a long amount of time, but hey, this is what could happen, or this is what did happen, and this is why we need to do the things we're doing. Sometimes we talk about, we need to do this because it's an accreditation requirement or it's a regulatory requirement, and so I understand that those conversations are sometimes how we get across to our providers, but I like to come at it from a different direction, and that is, why is this a regulatory requirement? Why is this an accreditation requirement? It's to keep our patients safe. Right? We're working with highly skilled, highly talented, smart people. Mm-hmm. And sometimes they are driven, not just by, you got to do what I do because I say you have to do it, but why is this important? And making sure you tell that story to not only your teammates, but the physicians. This is why we need to do this. It's to keep our patients safe. When we keep our patients safe, we protect you, we protect our business, and we protect our employees, right? So I think that's really important. I think, and lastly, get down to the granular, right? Like I talked about, like what are the evidence-based practices that we can do, in this center to improve patient safety? And, the IHI, the AHRQ, ASCA, right? Look to our, to those resources because they have a lot of the answers. You don't have to create the wheel here, right? So, like I said, patient safety huddles, intentional safety rounding. It's something that not a lot of our leaders do in the ASCs. Mm-hmm. But again, another evidence-based tactic you can take back and start doing. And it not only drives outcomes, but drives employee engagement, employee retention, because you're out there asking the hard questions, right? And then doing something about it. And that makes our employees feel valued.
And I want to finish by kind of going back to what we started with, and that is making sure that we prepare our new employees, the people that you're bringing in for their job. I have seen, unfortunately, especially post-pandemic, where we're having a crisis in trying to find staff, that we sometimes hire people and throw them right into the fire. Quite literally, sometimes it seems. So I think what you're talking about here, and your own experience, your own personal experience, shows the importance of getting them well prepared for that for their position and what they're going to do, and probably more importantly, the culture that they've walked into, and help them to become part of that before they get very disillusioned with it. Any advice on how to do that and how to make sure that people have a good experience when they first come on board?
Yeah, absolutely. So one of the things that I talked about yesterday is that first day.
Yes.
Right? That first day when they walk in the door. You have to have had a plan well in advance of that. Where are they going to be on their first day? What is their education going to look like that day? Where are they going to have lunch? Are they going to feel included in your team? Have all of their paperwork, their competencies ready. And if you don't have those built out, you have to do that, right? The worst thing you can do on the first day is be met at the front desk and they're like, oh, who are you? And why are you here again? And I don't know who I'm going to put you with. Maybe Joe, maybe Sue. We don't have your paperwork ready, so just follow them around, right? So making sure that you have a complete orientation program built out. It's just like the culture plan. right? You have to put some time and attention into it. And so if you don't have a comprehensive onboarding program, you need to build one. Right? And I'm sure you have colleagues that can help you find resources or help share their programs. I know at SCA we're definitely team players, and we like to do that. So I think that's really important.
Jamie, thank you so much for your time. I really appreciate it.
Yeah, absolutely. Thanks for having me on.
Right.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
So as we get to the end of the year, everybody's thinking about what's happening next year. If your accreditation is due next year, you might want to visit with your accreditation organization. Most of them have annual conferences. I can't be sure that everybody does, but at least we know that AAHC and Joint Commission does a periodic conference. I think AAHC does it twice a year. I think Joint Commission does it once a year. So,
and I think with AAHC, it might be – so the one we have here is in person. Then I think they had a virtual one.
That's correct.
But their in-person one, Achieving Accreditation, is March 20th and 21st, 2025 at the Renaissance Orlando at SeaWorld in Orlando, Florida.
And the Joint Commission on Ambulatory Healthcare Conference is November 5th and 6th, 2025 at the Crown Plaza in Chicago O'Hare. Yeah, and then that's in Rosemont, Illinois. And another point I should make, and Sue mentioned this earlier, is that there are virtual conferences. I know AAHC's is very popular. Now, one thing to note is that we are working on doing a survey preparedness conference, hopefully sometime in 2025. More information to come on that. It'll be a much more generic conference, not so much focused on individual accreditation organizations, but preparedness for deemed status surveys, preparedness for certification surveys. So more to come on that as we get into 2025.
And the Georgia and South Carolina ASC Association's semi-annual conference and trade shows is March 20th and 21st, 2025 in Atlanta, Georgia, the Renaissance Atlanta Waverly.
The Florida Society of Ambulatory Surgical Centers Quality and Risk Management Conference is April 10th and 11th, 2025 at the Renaissance Tampa International Plaza Hotel.
And ASCA 2025 Conference and Expo is April 30th to May 3rd, 2025 at the Gaylord Rockies Resort and Convention Center in Denver, Colorado.
And the Gulf States Conference, which includes Alabama, Louisiana, and Mississippi, their conference is going to be June 11th through the 13th, 2025 at the Ritz-Carlton in New Orleans. Yeah.
The Florida Society of Ambulatory Surgical Centers annual conference and trade show is July 23rd through the 25th in Hilton, Orlando.
And the Washington Ambulatory Surgery Center Association's 2025 Annual Education Conference and Trade Show is November 6th and 7th, 2025 at the Tulalip Resort and Spa in Tulalip, Washington. And I think I'll probably be there again. And don't forget, there are on-demand versions of our ASC Director of Nursing, ASC Administrators, and the ASC Business Office Managers boot camps. And that's available on our sister website at ASC-Central.com. And I'll provide a link to that. And just a reminder to everyone to become a patron member of the podcast. Don't miss out on the benefits of joining our patron member program, which is available at ASC-Central.com. It's a comprehensive membership platform, and it's a go-to resource for all aspects of ASC regulatory and accreditation compliance, operations, and financial management. It's designed for the busy schedules of administrators, nurse managers, and business office managers. By becoming a member, you gain access to regular Zoom sessions, typically held weekly, where you can engage with other patrons and our podcast team. But that's just the beginning. Your membership unlocks a wide range of resources, including some of our virtual conferences that include our credentialing conference that Sue referred to earlier, the Conditions for Coverage conference, and you also find valuable tools like sample policies, procedures, forms, and our highly regarded fire and disaster drill kits. Your support through the Patron Program helps us to maintain and grow the podcast, covering the essential costs such as research, travel, equipment, and production. To learn more and become a member, again, visit ASC-Central.com.
Thank you for tuning into this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community and be sure to subscribe so you never miss an episode. We appreciate your feedback and suggestions for future episodes. Reach out anytime at comments@ascpodcast.com.
And a special thank you goes out to our incredible team here, our sound editor, Susan Cronkite, executive producer, John Goehle, and our committed research team of Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Alex Borneman, Zach Kelleritis, Jim Masters, Amy Cronkite, Lori Rodericks, Kathy Foti, Donna Macchio, and Christina Norman. Your hard work makes this podcast possible. Our theme music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we'll see you in our next episode.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, Trivalence, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServ offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping to standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our webpage at ascpodcast.com.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. And we would love to hear your questions and comments. Please email us at comments@ascpodcast.com.